Thank you all. I'm pleased to co-chair this session with the president of the International Contrast Ultrasound Society, the world-known Steve Feinstein. So we have a fantastic session on I cannot do an echo without contrast. This is really a masters of contrast ultrasound who will tell us how can we use this wonderful technique in the daily clinical practice. I would like to invite the first speaker, Professor Arnaldo Rabikowski, MD FASE from Rio, from Brazil, who is a past president of the Cardiovascular Imaging Group of Brazil. He's an honorary fellow of the American Society of Echocardiography, and he will tell us about, well, I cannot do an echo without contrast, exclamation mark. Arnaldo.
May I share my screen?
Yes.
Can you see?
Yes.
Okay. Good afternoon to everybody. It's a great honor to do this presentation. I want to thank the ICOs and Steve for the invitation, and tell there is an honor to be beside such wonderful people that know contrast very, very well. So I have no disclosure. Hold on. So the micro bubbles, they are smaller than red cells and cross the lung capillaries. So those are the commercial available contrasts. In my country, we use the Sonoview. This is the only one commercial available contrast. And you can see that they have less than 5 microns. That's the reason they cross the lung and they go to the left heart. And this schematic illustration shows the stable cavitation of a microbubble in the oscillation pressures of the ultrasound field. When to use the contrast? Remember, the contrast is no ionizing radiation or risk of nephrotoxicity. And it improves endocardial border delineation, it enhances Doppler signals, it confirms or excludes thrombi or masses. Perfusion it can use for perfusion. We use a lot in stress echo. You use in HCM, in non-compaction, in aneurysms or pseudoaneurysms of the left ventricle. In Takotsubo disease, it can also be good for to detect wall motion abnormality without perfusional deficit. This is the protocols that was made last year from the ICOs. And this protocol is based on more than 2 decades of use of contrast. The attention in this guideline is given to preparation, dosing, is set in the preset of the machine. This is the way we start to do the contrast. In our country, or the doctor or the nurse it's allowed to make the vein puncture, and we use one of these stopcock, the vial, to introduce the contrast. You use we use in bolus, and we do a very slow injection, and after the injection of the contrast, we use a slow infusion during 3 or 5 seconds. The contrast enhancing agent has a great impact in patients with reduced ejection fraction. In 176 patients, this paper was published in 2017. In 176 patients, 137 men, and the mean age 60 years. in patients with technically difficult transthoracic echocardiographic studies. Ultrasound enhanced agent enabled biplane left ventricular ejection fraction measurement in 97% of studies, and the interpretation of regional wall motion in 95% of studies. The presence or absence of left ventricular thrombus in 99% of cases. Change in management occur in 51% of subjects. The routine use of contrast on the admission transthoracic echo for heart failure reduced the rate of repeat studies. So routine use of ultrasound enhanced agent in transthoracic for patients with heart failure reduces the rate of repeat echo during admission. This is the paper published in the Journal of the American Society of Echo in 2021. So in 9,100 admissions, ultrasound enhanced agent was done in 5,600 patients, and no contrast was used in 3,500. 104 patients who underwent unjustified repeated transthoracic, 76 belongs to the non-contrast group and 24 to contrast group. The mean length of stay in hospital was lower in contrast group versus patients who did not use the contrast. Let's show a few examples. This patient is a man, 88 years old, obese, diabetic, and with shortening of birth. 3 years ago, he had a lesion in the diagonal artery. So we do the perfusion. You can see that there is no perfusion in the apex now. Again, we do the flash and no perfusion in the region of the left anterior descending artery. So this is his CAT at 3 years ago. And you can see there is only a lesion in the diagonal artery. And now he has an important lesion in the LAD, proximal in the LAD. So this patient went to the cath lab and he went to angioplasty with the introduction of stent. This is a patient. You know that in Brazil we have a lot of patients with Chagas disease. And in this contrast study, we can see the typical aneurysms of the Chagas disease in the apex, that it was hard to see in the use without contrast. This is a patient with difficult echo. We see in the left patient without contrast, we hardly see the left ventricular border. In the right with contrast, you see very well the function of the left ventricle. Another case of difficult studies, you see how better we see the left ventricle, we can assess the left ventricular function. Another indication of the use of contrast is for detection of thrombus. We can see in the left without contrast thrombus, but we not see as well as when you use the contrast. You see there is more than one thrombi in the left apex. Again, patient with thrombus in the left ventricle, you see in the upper left, we hardly see the thrombus. So when you inject the contrast, you see very well the thrombus. Another use is for patients with suspicion of thrombi in the left atrial appendage. You see, we can affirm there is a thrombi or is only a contrast in the left atrial appendage. After the injection of contrast, we see very well the thrombi in the left atrial appendage. So this patient has canceled. Here you see also the thrombi. So in this patient, have canceled the cardioversion because of this finding. And of course, we cannot forget to use the microbubbles, but this one is not the commercial available. It's only agitated saline to detect a shunt, an intercardiac shunt. So a simple agitated saline can give this information. Another use of contrast is in patients with hypertrophic cardiomyopathy. And this paper was published in the Journal of the American Society in 2020, comparing the echocardiogram with contrast with the MRI. And as you can see, on the left is a regular echo without contrast. In the middle, patients with contrast, you see how close are the image to patients with with MRI. So it's very close to the MRI and the measurement of the wall in this when we use it. So we routinely use the contrast in patients with hypertrophic cardiomyopathy. This is an example. This is a patient with 30 years old, submitted to myectomy, moral procedure 3 years ago. Now she complained of shortness of breath and chest pain. We see a thin intraventricular septum where the procedure, the myectomy was done with here, and you see very well the walls of the left ventricle. We see the muscular band of the right ventricle. And remember, this patient also complained of shortness of breath. And we see here how, with contrast, how we can erase the view of the septal arteries. So don't forget this, that those patients has an intimal lesion of the coronary artery. So there is a reason for her to has a chest pain. And we see in this one, in the one in bottom, we see how nice we see the anomalous papillary muscle in the left ventricle. This is another case of hypertrophic cardiomyopathy. It's a patient with Yamaguchi, apical hypertrophic cardiomyopathy. And we see how nice we can delineate the hypertrophy in the apex of the left ventricle. And this one is another reason to study the hypertrophic cardiomyopathy. It's a patient with midventricular hypertrophic cardiomyopathy with aneurysm formation in the apex. There is very common to have thrombi in this kind of hypertrophic cardiomyopathy who develop aneurysm. So, in conclusion, a modern echocardiographic laboratory cannot work without the use of contrast. And as Professor Feigenbaum once told me, worse than not having a diagnosis is having a wrong diagnosis. Thank you for your attention.
At this moment, Dr. Robanovsky will need to leave before our Q&A period. So any of the audience that does have a burning question for Dr. Robanovsky, we should have you type that real quickly into the Q&A. We will lose him before we get to our scheduled Q&A. And then if none come in for Dr. Robanovsky at this point, but come in later, we can forward those on to him.
While waiting, can I ask, in fact, amazing, very good presentation, Arnaldo. Some of the images you showed in hypertrophic cardiomyopathy comparing with MRI, I wasn't quite sure which is the contrast echo images and which are the MRI images. Quite impressive pictures. The one previously
May I
compared
go
with
back?
MRI.
You see
This one.
this
Can
one
you
is
show
not-
to the audience which is the contrast echo and which are the MRI images?
The one left, the panel in left is without contrast. This one is the echo with contrast, and this one is in the right is the MRI. We see how close are the image, echo image with the MRI.
Yeah, very, very, very impressive images. Now I do not see no open questions yet. Yeah. Okay.
So we are far from you. It's a great honor to share with you this session. Thank you, Pat.
Can you give us an approximately what % of echoes during your daily practice you use contrast echo?
I think about 20%.
20%. That is quite an impressive number. And final question from me, whilst there are no questions from the audience, who is doing the injections? Is it the doctor, or do you have qualified nurses or echocardiographers, sonographers who do the injections?
Now, in the majority of cases are the nurses. We train them, and then there is no problem. They can in 5 minutes, if the patient is outpatient, they have the access and they inject. So it worked very well. We don't have problem to do that.
So is it fair to say that in Brazil, qualified nurses can inject contrast?
Yes, but remember, I work in a private hospital. In public hospital, I think it will be very hard to establish this routine.
Okay. Point taken. Thank you very much again, Arnaldo, for this very good presentation. Steve, shall we go on to the next presentation by Jordan?
Absolutely. I'll follow your lead.
Okay, so next presentation will be delivered by Jordan Strom, FASC. He is the director of EchoLab in Beth Israel Medical Center, and he is a section head of cardiovascular imaging. So Jordan is a core member of the International Contrast Ultrasound Society. Jordan, he is a named king of contrast for this session at least. Let's see. Jordan.
Well, thank you very much. Thanks for the introduction, and it's very nice to be amongst esteemed colleagues here. We also use contrast quite readily at Beth Israel Deaconess Medical Center, where we've actually grown the program from about 2% contrast use to about 22%. We know about 10 to 20% of all echocardiograms have suboptimal image quality, and we have our sonographers trained through and credentialed through the hospital. We do an annual training and credentialing process with them to make sure that they are able to give and do give contrast at bedside. And so they do this based on the review of the images, and that's worked very well in terms of getting this important technology into the hands of individuals. Importantly, so before I move on, if you're thinking about training your lab to do this, we've done a sort of extensive legal review, and we're not aware of any state laws governing sonographer use and injection of contrast, and this is supported by both the SDMS as well as the American Society of Echocardiography. So it's an important topic, and obviously practices differ on a local basis, but this is it's a quite valuable technology, and it's something that sonographers are frequently trained to do and are within their wheelhouse. So with that in mind, I'm not necessarily the king, but I will tell you why Bubble is. So these are my disclosures. So we will be talking about ultrasound enhancing agents, which is the other word for contrast. Sometimes patients don't like to hear the term contrast because they confuse it with iodinated contrast, which is very different in structure and also adverse events. So we use the term ultrasound enhancing agents. And just to remind everybody, that those are FDA approved for the indication of left ventricular opacification only at this given time, but we will be discussing other indications for left ventricular opacification. So we'll examine data supporting the underuse of contrast-enhanced ultrasound for cardiovascular ultrasound in the US. We'll review the benefits of contrast-enhanced ultrasound for echocardiography. And in addition, we'll illustrate the benefits of contrast-enhanced ultrasound for COVID-19 and chest pain evaluations very specifically. So we'll start off with the case. I think this is something that's been familiar to many of the people listening, but COVID is, of course, taken the medical world by storm. And so this is a very frequent circumstance, unfortunately, where you have a patient who has COVID, who's intubated in the ICU with hypoxic respiratory failure and is unable to give you a history, but perhaps has some interest or has some risk of underlying cardiac disease. And when it's measured, you find that they have an elevated cardiac troponin on emission. And one of the questions is that elevated cardiac troponin simply due to demand from their underlying hypoxic respiratory failure, or is there an acute coronary event or some coronary history of MI that could potentially explain this finding? And so here, this is a very common image to get amongst those of our patients. We know that the patients in the ICU are frequently intubated, have aerated, a lot of aeration in the lungs. It can be very difficult to move them to get windows for this. And so this patient is intubated, and this is what we would call in our lab nocardia. You can't see anything in terms of the endocardial borders, and it's very difficult to discern what is going on at all. By contrast, once we give the actual contrast, we can see very clearly here in this apical two-chamber view that there's an inferior wall deficit and akinesis or hypokinesis of that inferior wall. And this patient actually had an underlying acute myocardial infarction. So contrast is incredibly helpful. And I'll go over some of the reasons why, but I wanted to start by talking about how it's underused within the United States. So in general, and I'll show you some data behind supporting this, we believe that contrast is used in about 6.8% of all transthoracic echoes and about 21% of all stress echocardiograms using sort of national data that encompass about 90% of the US population. Again, as I was saying earlier, the estimated rates of suboptimal image quality are about 10 to 30%. So if you do the numbers, I think you can see that there's far more patients with suboptimal image quality than we're using contrast in. And the rates of suboptimal image quality, at least in this one study that we published in the Journal of American Society of Echocardiography, seem to be rising faster than the increase in contrast use. So even though contrast use has been increasing, it hasn't been increasing relative to the rate of rise of suboptimal image quality. And that is, in part can be explained by increasing rates of obesity and a broader use in echocardiography in the population that we treat, and therefore much more challenging windows than perhaps we had even 5 or 10 years ago to deal with. Moreover, if we look at the variability in where contrast is used, and these are unpublished data as of present, looking at variation and variability in contrast-enhanced ultrasound use across the United States. And you can see in the red here, those are areas we're using quite a bit of contrast, and the lighter shades are areas where they're not used as much. And simply walking into a hospital in Minnesota, your rate of use of contrast is higher than if you were to walk into a hospital in Delaware with the same complaints. We think that the use of contrast is about 20% of transthoracic echoes in Minnesota and about 1.1% of those in Delaware, looking at the extremes of the situation. And if you account for known patient and hospital factors, that doesn't seem to explain differences in the significant variability across sites in contrast use. So there are practices that are different across places. And how do we serve our patients best? Well, we would serve our patients best by all using this it for the appropriate cases, and those are ones that I'm going to discuss. So what are the problems? Well, there are a lot of barriers that start, and those start early in people's overall training. So this was a survey put out by Dr. Movag, who will be speaking to us very shortly, and others. It was published in JACE and was a survey conducted by ICUS to 227 program directors. They had a 67% response rate, so pretty good. And they found that only 18% offer any kind of training on IV insertion, which is one barrier to use of contrast, particularly in the outpatient setting, and only 5% certify sonographers on placement of IVs. By contrast, technologists that work in MRI and CT are trained on IV placement. So there's a very big difference there. There's also not more than just the IV itself. There's not a lot of discussion on and training in many areas on contrast enhanced ultrasound itself. And part of that, and the majority of that, as you can see here, is they ask people if for those answering no to having contrast enhanced ultrasound in the curriculum, what are obstacles to implementation? And the top thing that came to mind was current educators don't have sufficient expertise. And so that's where the ICUS and where other ultrasound societies can really have a significant role in expanding that training expertise and allowing you to be able to use this at a point of care. So with that in mind, we've established that it's underused. What are the benefits of using it? So many of them have already been mentioned, but this is just a couple summary slides looking at these. But for left ventricular quantification, the LV diameters are larger with ultrasound enhancing agents. And in fact, actually the inter-observer variability in LV ejection fraction is reduced with ultrasound enhancing agents and becomes similar to that of cardiac MRI. For looking at regional wall motion changes, there's improved inter-observer agreement compared to unenhanced imaging, and it improves the confidence, sensitivity, and specificity for stress interpretation in technically difficult studies. For the evaluation of intracardiac masses, there's been quite a bit of work done in this area, and it improves the distinction between avascular and vascular structures. Dr. Movega, again, published this really important work on use of ultrasound enhancing agents in improving identification of apical hypertrophic cardiomyopathy and aneurysm. And for those who are evaluating patients for TEE, pre-cardioversion, it improves your confidence for thrombus exclusion prior to cardioversion and may in fact actually be associated with reduction in embolic events following this. For left ventricular pacification, it improves accuracy, reproducibility, and reader confidence. 99.3% compared to with diagnostic images. And then ultimately may be associated with lower downstream testing and cost because of improved decision-making capacity. For using perfusion imaging or inotropic stress, it can improve the detection of coronary disease versus wall motion analysis alone, and can define the extent of wall motion abnormalities, and improves upon wall motion analysis in identifying those at risk for death and subsequent myocardial infarction. Looking at vasodilator stress, it's equivalent specificity and higher sensitivity than SPECT, and has enhanced prognostic value, perhaps versus SPECT in multiple studies. In those with left bundle branch block and non-ischemic wall motion abnormalities, it improves the detection of ischemia versus SPECT. And for quantitative perfusion, it has a sensitivity and specificity greater than 80% versus angiography, the gold standard. It also supplies superior prognostic information versus qualitative information. So what's the problem? Well, if you read Gomer blog, this is it's a great blog, and it has a lot of very funny pieces in it. This is one of the things that they published on it. ICU team excited to untangle lines after patient dropped off from OR. I think this is all familiar with a lot of people who may be listening. We're all used to patients who have very acutely ill and have many things going on with them at the same time. And accurate and efficient decision-making in that setting is really critically needed for these most critical ill patients. But the challenges are multifold in obtaining adequate quality images in the ICU. There's difficulty with patient positioning, and setting of mechanical ventilation makes that acoustic windows may not be present, and wound dressings may impair the views from which you can actually identify the endocardial borders. So in terms of the ICUs, this was a study published by the Houston Methodist Group back in 2009, and Jack, really important study looking at 632 patients who received ultrasound enhancing agents. And here you can see in the red, those studies that were technically difficult. Yellow is those studies that were uninterpretable. This is all prior to the use of ultrasound contrast. And you can see that up to 10%, up to 25% actually in the surgical ICU were uninterpretable prior to the use of contrast. And this is after the use of contrast. And I think just visually, you can see the quite significant difference here in that many more of the studies were adequate quality. The rate of uninterpretable studies dropped down to nearly zero. and the rate of technical difficult studies dropped down significantly as well. And to put some numbers on that, the uninterpretable studies dropped from about 12% to 0.3%, and technically difficult studies dropped from about 90% down to 10%. And this had the highest impact in the ICUs, where 78.4% became adequate in the surgical ICU. And that really suggests that these patients who are most critically ill, for whom this really matters, have the most to gain from the use of contrast. And so what did this do to downstream utilization? Well, ultrasound enhancing agent use resulted in avoidance of further diagnostics in about a third, with most in the surgical ICU, and about a third of those in the medical ICU. And you can see that some of that was a TEE that was avoided, or a nuclear imaging that was avoided, but it also led to significant changes in management as well. So management was changed in about a third and about 2/3 of CEUS echocardiograms, including avoidance of procedures like coronary angiography, as well as differences in medications as well. So when you think about this in terms of cost effectiveness, if the cost of contrast in the study in $2008 for those 632 patients was about $40,000, if you then look at the cost of the avoided procedures, which is about $116,000, there's a net savings of about $76,000 or $122 per patient. So on average, the use of contrast really improves the cost effectiveness because you are able to target people to the appropriate procedures and not overuse or underuse procedures in the case of where it be necessary. So all in all, with a cost-benefit analysis, they concluded that about $189 was spent to avoid one diagnostic test. So talking about acute populations, the ED is another acute population where echo is often necessary for expedited assessment of chest pain in the ED. This is chest pain rollouts affect over 5 million individuals annually, cost about $10 billion annually to the United States government. There are, and of course, the problem is that cardiac biomarkers, EKGs, and symptoms can be equivocal and contradictory. I think many of the people listening may know that. And image quality may limit wall motion analysis in patients who are presenting with such symptoms. And so what can we do? What can we do differently? Well, this is a great paper that was published in Chase by the OHSU group, looking at developing of a predictive instrument using contrast echocardiography for patients who are presenting to the emergency department with chest pain and without ST segment elevation. And they looked at about 1,000 individuals presenting there with chest pain that was more than 30 minutes. And they developed and validated a risk model for prediction of that cardiac events in 720 individuals. And they assigned 1 point for non-specific ST changes, EKG abnormalities, abnormal regional perfusion, but then they also looked at abnormal myocardial perfusion. And you can see that they had a fairly good tracking with the risk of cardiovascular events in this population. And if you take that one step further and evaluate the use and cost effectiveness of myocardial contrast echo in patients with emergency department with chest pain of unclear origin, this is you can see that this approach would have prevented 207 admissions for chest pain, decreased observation for 316 others with normal myocardial perfusion. The cost was less than compared to usual care. And in net, there was about $900 per patient saved, about $861,000 overall. So the cost, they concluded, of myocardial contrast imaging would need to exceed $1,151 before the cost of usual care was exceeded. And so, this really is a very good and cost-effective technology. Now, fast forward a little bit to COVID, and I don't want to bring up bad memories for anybody else here, but this was a very uncertain time in the very beginning of the pandemic, and it was unclear how we could best protect ourselves against this disease and protect our staff as well as our patients against this disease. And the ASE as well as ICUS came out with statements about the use of contrast in this regard. ASE issued a statement very early on in the COVID pandemic, stating that exams should be focused yet comprehensive to avoid the need for return for additional images, and that each study should be tailored to the indication planned in advance after review of the prior exams for those patients. Plans for ultrasound enhancing agents should be made in advance to avoid sonographer waiting for an agent to be delivered or extra use of PPE. And key here is that ultrasound enhancing agents were preferred and used because they can reduce the struggle time to obtain adequate quality images and thus reduce the exposure. So the use is overall encouraged overall. Now, are they safe? So this is a great study from the Sinai group, 33 patients in Mount Sinai Morningside Hospital in New York City, 14 of which were on mechanical ventilation at the time. These were patients with COVID. As you'd expect, contrast improved the ability to interpret both LV and RV function. And importantly here, this showed that there was significant safety. There were no adverse events in this setting within 1 hour of the procedure of the use. So in conclusion, contrast-enhanced ultrasound, it remains underutilized for cardiovascular ultrasound, and it remains low in part due to issues with access as well as administration of these. But multiple benefits exist across to its use across the spectrum, including optimizing clinical decision-making and reducing downstream utilization. So really, we need to work as a society towards improving the utilization of these very important tools. And encourage anybody to have, if there are any questions, to ask them in the Q&A session after this. Thank you very much.
Thank you, John. Very, very nice. You covered a lot of issues concerning the use of contrast in daily clinical practice. Not sure I can see any questions. Probably you answered already all questions that people were supposed to ask. But can I ask, you made such a convincing argument. Why do you think in the US there is still a rather low take of use of contrast in daily clinical practice in many labs? What are the main hurdles?
Yeah, I think that's the million-dollar question here, and I think use of contrast tends to be fairly binary, in that you're either a lab that's using it and using it at a high volume, or you're not using it at all. And so there is a bit of that involved. But ultimately, I think there were sort of early concerns about safety that I think have subsequently been exhaustively tested. We know that contrast agents, or ultrasound contrast agents, I should say, are amongst, if not the safest of contrast media, with a rate of a rare case of sort of anaphylactoid responses, a Carper reaction, about 1 in 10,000 that receive it. So part of it is safety, and this lingering concerns about that, despite very robust safety data, 4 million plus patients published by Mike Main and others on this very topic. And part of it is that there's an IV problem. Patients presenting to the outpatient lab don't have IVs placed. There may be delays in calling for those IVs to be placed, and so as a result, people defer the use of contrast rather than wait the time for the IV nurse or whoever else to place the IV and then to subsequently give the contrast agent. Part of it is unfamiliarity. People don't necessarily have training on contrast use, and they may be unfamiliar, and they don't have advocates within their lab or others. Really importantly, you really need an advocate within your center or site to be able to drive use of this and to be able to champion use across the medical center. And so part of it is where people trained. It's force of habit, and it may be a consequence of where ultimately people trained, and if they were exposed to contrast use in their training site and what they're used to doing or not doing. So I think there's a lot of different avenues in which we can ultimately try to improve upon this. But I think it's multifactorial, and despite now a wealth of data suggesting there's a real substantial benefits of use, we remain lagging behind where we really need this technology to be.
Sure. And this is really the role of CEUS in continue doing these webinars, so we can train and convince both sonographers and doctors to use contrast in their labs. That they go hand in hand. Sonographers should really request the doctors to allow them using contrast as often as possible and when needs arise. Okay, thank you, Jordan, very much. So
I think Dr. Feinstein has
Yeah.
a quick question.
oh, good.
Thank you very much. I do see there's a question for Jordan. And let me just say that I see the list of attendees, and I would encourage the attendees to participate and let us know, and your colleagues here, how many of you are using contrast on a regular basis. That would be fascinating for us, and how, on what indications. Now, I do want to highlight one of our participants is Dr. Viktor Zilov. He is in the Ukraine. He's a pediatric radiologist, and his pioneering efforts to actually diagnose and save children in Ukraine is well recognized now. So thank you for joining us, Victor.
And Sharon, I don't want to cut too much into your timing here, but I just want to address the question that was asked in the Q&A very quickly. It was the question, to repeat, is: do you have a specific explanation that your texts give to patients so that they inform patients properly? Also, do you know if this is something that needs to receive a prior authorization by insurance companies, or is this a generally covered procedure? So I'll answer the second question first, which is it is very much a covered procedure. There are specific CPT codes, as well as NDC codes for the use, or national drug codes for the use of contrast enhanced ultrasound, and it's billable, at a higher rate than your standard unenhanced echo. So it is that is there. And in terms of the explanation to inform patients, we try not to address this as contrast. We say this is part of a routine examination that helps us better understand and delineate the cardiac borders. What it does is it helps our decision making and helps us better understand and see pathology when it's present. And I think if you take that kind of tact or angle towards it, then certainly there's not we have not seen a lot of resistance to use of this, and I think it's helps to level set with the patients ahead of time. All right, well, thank you very much, and I'll turn back over to Petros to introduce Dr. Molbech.
Excellent. So the next speaker is the Queen of Hearts, as we can say, Professor Sharon Mulvey, who is a professor of medicine in Dalhousie University in Halifax, Nova Scotia, in Canada, and she is emeritus professor in Mayo Clinic in Rochester, Minnesota, as well. And she is current president of the Canadian Society of Echocardiography. So a very important person to tackle the question of the Queen rules when CEUS is invaluable. Sharon.
Thank you. Thank you so much, Petros, Steve, and for the excellent presentations from Ronaldo and Jordi. And thank you to all you participants who are here joining us today to learn more about contrast-enhanced ultrasound. I have a couple of disclosures as indicated here. A relevant one would be that I'm a consultant for Lantheus Medical Imaging. I also do have a few research grants, but they do not involve contrast at the current time. Well, actually, that's not true. One does. So I just want to go over more of a case-based approach right now. You've seen some excellent examples from my colleagues. And just like an idea of how we approach and when do we really need to use contrast-enhanced ultrasound. And actually, this is I love this diagram. It's taken from our great colleague, Jonathan Lindner, who developed it, and it's published in Catherine Otto's textbook of clinical echo recently. And the idea is that, sometimes even though you may have excellent images, you still may need to use contrast to be able to get more information that you want. So if you have a patient with chest pain and angina, as Jordi was going over Dr. Kevin Way's information from the ER studies that he did, even if you have a good definition of the endocardium, you may want to have that perfusion information on top, right? So you may consider using contrast in that situation. Similarly, to be confident to rule out a left ventricular thrombus, to be confident to rule out left ventricular apical hypertrophy, these are the sorts of things that we think of. It's not just like what the quality of the image is, but it's also how much benefit you're going to get potentially from the ultrasound enhancing agent. So the bottom line is, if you're unable to get the information, the clinical information is pointing you in the direction that you're suspecting a diagnosis or you need to rule out a diagnosis, then that's when you should think about using ultrasound enhancing agents. Let's do a couple of cases then. Here is a young woman who came in with chest and jaw pain. She has real, and this is the Mayo format, so the LV is on the left here. And, you know, she does have very nice endocardial definition, but clearly there is increased echogenicity at her apex in this apical 4-chamber view. And here in this short axis view, which is a left ventricular apical focus short axis view, you see that there is a lot of extra material here. And so it's not just to be able to further define this, but it's to characterize what is this echogenic material at the apex. And here is a apical long axis view, and you can see that the apex is truncated here. There is no perfusion of the mass that is present at the apex, and there's a tiny channel, which is actually best seen over here in the apical 2-chamber view, of the microbubbles being occurring to extend into a little sliver, a little channel in whatever this is at the apex here. And so the point is that this is non-perfusing, and that it is there are areas that can be penetrated in this mass at the apex. And this appearance is most consistent with, can you guess? Yes, hypereosinophilic heart disease. And let me just go back to that last slide for a moment because it just scooted ahead too quickly on me. Apologies. And you can see that this patient did go on to have biopsy, and eosinophilic infiltration and degenerating thrombus is what that echogenic area was that didn't have any perfusion, obviously. There was no presence of microbubbles. So you could be certain that this was not a tumor and this was not myocardium. So this is how, not only in the definition of the wall motion and the cavity or the cardiac structures, but also the characterization of those structures. Here's another apical abnormality. A 72-year-old male presented, and this is a case that actually Roxy Sr. in the UK shared with me many years ago, but it's probably the best case that I've really seen, so I still like to use it. This patient came with an incidental finding of on his chest x-ray of a mass adjacent to his heart. And that mass is clearly seen here. Well, it looks like an echolucent cyst or something, doesn't it? And here the LV is on the right in the conventional format. And you would wonder, is this adjacent to the heart? Is it connected to the heart? How are we going to figure that out? Right. Well, we give ultrasound enhancing agent. And you can see here that this mass, this large cystic mass here, is filled with microbubbles when the injection occurs. And you notice that it is coming right through the left ventricular apex. So this is the narrow neck of a left ventricular pseudoaneurysm, because the body of this aneurysm is larger than the neck. So this is by definition a left ventricular apical pseudoaneurysm. And this patient had actually had a silent myocardial infarction and fortunately did not have any complications with this, but clearly he was coming for non-cardiac surgery when he had presented, and this was an amazing case. How about this woman? She's an elderly woman who had had a transapical TAVR performed, and routinely echoes are done prior to discharge. And this is the conventional format with the LV on the right. And you could see at baseline that her images were very difficult. So we went ahead and gave contrast in this situation to improve the endocardial definition, which you could see she has normal LV size and a very hyperdynamic left ventricle. So patients are followed up routinely about a month later. And when she came back, we knew that it was going to have to be a contrast enhanced study because of her difficult images. So contrast was given, and lo and behold, look what is here at the apex. It is, this is in the apical 4-chamber view again, and here in an apical long axis view, you can see again the appearance of a narrow neck aneurysm. This was a left ventricular apical pseudoaneurysm as a complication of the transapical route that her TAVR had been placed. And this is actually recognized in about 2 to 3% of the cases that are done transapically. So this can be very helpful. Dr. Rabachowski already showed you some nice examples of a left ventricular apical aneurysm, and I'll just go through this quickly. This is a two-chamber view, and I'm sorry it doesn't play right now, but there was a little haziness at the apex. But when you give contrast, you can see clearly that there is like a light bulb stands out with this reverse light bulb with a defined apical, left ventricular apical thrombus. So in patients that have had myocardial infarctions, this is not uncommon. And it is the only way that many times we can confirm the presence of a thrombus is by administering contrast. So we've given some examples of intracardiac masses, and we've kind of gone over what hypereosinophilic syndrome looks like and what thrombi look like. What about other aspects that we need to look at? In general, when we're looking for, if we see an intracardiac mass, we want to define it in its size and its presence, but we also want to characterize it. And that's where we can use myocardial perfusion imaging. And these are low mechanical index images, and here the LV here is on the left actually, and you can see that there's a very large area of wall motion abnormality consistent with an apical infarction, a very large LAD territory here. And there is an echolucent area which does not have contrast in it, and this is a large sessile thrombus as a complication of the very large anteroseptal apical myocardial infarction. What about this image in the middle? Here, this is an RV focused view actually, and this is a mass that we see, and it looks like it has a stalk, but what we're really focusing on is the size. It's very large. And we're looking to see, is there any contrast within that? And you see, as we give that high mechanical impulse, and then afterwards, we look to see if there's filling within that mass. And you can see that as a contrast to this thrombus on this panel over here, this mass does have the penetration of microbubbles. So we know that this is perfused. And the low rate of perfusion and the presence of a stalk certainly make it highly clinically suspicious of being a myxoma. And on the far right panel here, you'll see this is another RV focused view where we have the entire RV apex, which is being filled with a mass, which appears to be echolucent. When we do our perfusion sequences by giving that high mechanical, there it goes, impulse flash, you can then see that there is rapid appearance of the microbubbles within that mass. And this would be consistent with a highly perfused malignancy, and this was actually a renal cell carcinoma that had metastasized. So not only can we characterize where abnormalities are, not only can we observe where abnormalities are better when we have intracardiac masses, but we can also characterize them. And just to review the perfusion technique, the advantages is that we use the same settings that we use to have optimal left ventricular pacification and endocardial border definition. We prefer to use very low mechanical index imaging with a slow infusion with either a hand or pump, depends on the agent that you're using and the country that you're in as to which you're likely to use of those. And then the additional step of doing that high, when you get a steady state appearance of the contrast microbubbles within the myocardium, you administer a high mechanical index, generally on the order of 0.8 to 1 flash exposure to deplete the microbubbles in the myocardium, and then you observe the replenishment as they come in over the next cardiac cycles. And this is clearly related to the rate of replenishment, we call that the beta, as well as the complete blood volume that ends up, and we call that the A, or the plateau value. And actually, if we multiply the beta by the A, we can determine what the myocardial blood flow is. Normally, we will see the appearance of microbubbles in the myocardium at rest in normally perfused myocardium within 4 to 5 minutes. And after stress has been administered with the elevation in heart rate, increased cardiac output, we will see the appearance of microbubbles within 2 cardiac cycles. And if this doesn't occur, then we know that it is either absent if we don't see any microbubbles, or if we see a slow rate of appearance, then we know it is delayed reperfusion. How about in stress echo? Well, we know that in stress echo, we actually, when I was at Mayo, you saw how Minnesota was kind of filled in and is like the high user in the country. And indeed, we probably used about 10% of our rest echoes had contrast, but the biggest use was in stress echo. And there we used about 40% in our exercise echoes and about 60% in our dobutamine stress echoes. There are other labs like Dr. Feinstein's who use stress echo 100% contrast. So maybe he'll want to make some comments on that later. But the advantages here, this is a case, again, this is the Mayo format. So we have the LV on the left here, the RV on the right, and this is 4-chamber view at rest on the left images and post-exercise on the right images, and the apical long axis view here on the bottom panel. And this was interpreted as being a normal stress echo, but it didn't fit with the patient's clinical observation. And if you look carefully, you have to be very suspicious about the anteroseptal region here. And the other thing you notice is that the myocardium looks very thick at the apex. Well, this patient does not have apical, left ventricular apical hypertrophy. No, what this patient had was poor endocardial visualization, lack of complete endocardial visualization because these images are foreshortened. And so what happens when you use ultrasound enhancing agents is that you can avoid apical foreshortening. You can see now all the way to the apex. And when you can see all the way to the apex, you see that it's normal thickness myocardium. And moreover, there develops a regional wall motion abnormality with a severe hypokinesis from the mid-anteroseptal region all around the apex here in the 4-chamber view, as well as in the apical long axis view. So this is the infroseptum and the anteroseptum, which are very abnormal. And this patient went on to have a coronary angiogram and indeed had a very tight proximal LAD lesion. So it's important to recognize that not only does it improve endocardial border definition when you use contrast with stress, but it helps too when the patient gets off the treadmill, and often it's very difficult for the sonographer to get the image immediately. If you have contrast within the left ventricle, it's like a flashlight, a beacon. You can hone right in and get your images much more quickly. You can have complete endocardial visualization. You will prevent apical foreshortening, as I have demonstrated, and it will give you a more accurate interpretation. Studies have shown that this improves reader confidence and enhances a learning curve in novice readers so that they more rapidly become expert readers in a shorter period of time. Now, what about going the next step? I've talked about perfusion, the benefit of using that in masses and the characterization, the tissue characterization that you can have there. But it can also be very helpful in stress echo. And here's an example in a dobutamine stress echo. This is going between two different institutions. You know, one was the LVs on the left back at Mayo, and in where I am now in Canada, the LVs on the right. So this is the conventional format with the LV on the right here of a 4-chamber view. And you can see that at rest, there were no significant abnormalities, but this patient at stress clearly has apical dilatation. But moreover, you can see there is lack of perfusion in the apical region. So there is a perfusion wall motion match. Sometimes this can be even more helpful because if you notice, this was not even at peak stress. This was at 30 mics of dobutamine. So when you already see that you've got a perfusion abnormality, you can stop the test at that time and it can make this test more safe. This is an example of a patient who had an exercise stress. Now, it's a bit more difficult because you have to get your timing just right, and it's much easier to do this with a bike study as opposed to a treadmill study. But this would be another example. Things look pretty normal at rest in this 4-chamber view, but after stress, there was a clear wall motion and perfusion abnormality, which are matched here in the LAD territory. In our stress echo guidelines, we clearly recommend the utilization of contrast for LVO as well as for perfusion. Now, I should say that this, and I forgot to mention at the beginning in my disclosures, that perfusion is an off-label application of contrast at the current time, but it is recommended in our guidelines, not only our stress echo guidelines, but also in our contrast echo guidelines, the most recent update having been published in 2018. Now, a few more words about myocardial contrast echo perfusion. Why does it work so well? Well, with contrast, ultrasound microbubble contrast, The bubbles are pure intravascular tracers. They do not extravasate, and they are very representative of what the perfusion actually is in the microcirculation. And this is just an image over the left in the left panel of a barium cast, reminding us what the microcirculation looks like. And on angiograms, we can see maybe to 100 micrograms, but we will never see these 5 and 6 microgram vessels. But we can get this information in the microvasculature from our contrast perfusion imaging. Where perfusion can be particularly helpful and incrementally helpful is, as I've already mentioned, in characterizing masses, in assessing tissue viability in patients that have chronic ischemic syndromes, in suspected cardiomyopathies, differentiating between dilated and ischemic cardiomyopathies, and as has already been demonstrated to you by Jordi, in the chest pain assessment in the emergency room. And then also, Jordi mentioned a little bit about use of contrast perfusion in addition to our stress testing with patients that have left bundle branch block pattern, when it's very difficult to assess the wall motion assessment because the dyssynergy that is created by the bundle branch block. If you have the perfusion information, that can be extremely helpful. And then in multivessel coronary artery disease, where you sometimes can have a balanced ischemia, this can also be of significant benefit. A few other things I'd like to touch on where contrast is not conventionally used, but certainly can be helpful, is assessment of mechanical circulatory support devices. And we did look at our data in patients that were on ECMO and found that, yes, it can be very helpful. Here it clearly outlined this mass, which was extracardiac in this patient who was on ECMO. And it's very safe to use, but the proviso is that you do have a perfusion specialist available, because the microbubbles can activate the alarms in the pump, which could potentially get set off. And so that would be important to have available. Similarly, in LVADs, this is showing an appearance of a thrombus that is at the site of the cannula. And we looked at our data at Mayo. Noel Fine put this together and found that again, it was very safe, and that it changed therapy in almost half of the patients by the information that was obtained. I'd like to just share with you 2 quick cases to finish up here, and that is how it can be helpful to assess. I know mentioned was Takotsubo evaluation. So this is a woman that we saw in consultation. This is an apical long axis view, and you can see that despite this large wall motion abnormality here with the relative hyperdynamic function at the base, this was a couple of days after she'd come in, that there is normal perfusion. So there's a mismatch here of the wall motion abnormality with the perfusion. And the question was, she had significant renal dysfunction. And the question was, does she need to have a coronary angiogram because she'd had a troponin bump and was classified as a non-STEMI? And because of this appearance, we suspected that she most likely would have recovery, because this would indicate there's viability of this muscle here, and that probably her clinical scenario fit more with a Takotsubo. And there was more risk to proceeding to coronary angiography than there was in treating her medically and following up. And we did follow up, and indeed, she had complete recovery of that myocardial function. And so retrospectively, she had confirmed a diagnosis of stress-induced cardiomyopathy or Takotsubo. She had come in with an anaphylactic reaction to an ACE inhibitor. In contrast, this is a very similar looking appearance in this patient who underwent a renal transplant, and she actually just had no symptoms, but the pre-dismissal electrocardiogram showed a STEMI. And so the question was, what's going on here? So the echo had shown the regional wall motion abnormalities consistent with an LAD infarct. And you could say, well, it does look a little bit hyperdynamic at the base here. Has she had a Takotsubo event? But look, there's no perfusion in this area at all. And she did go to cath, and she did have a tight proximal LAD stenosis. And she came back a couple of months later. And unfortunately, you can see that she does not have recovery in this area. And despite being, she had undergone a PCI to the LAD, but unfortunately, she did not have any recovery of her function. Tom Porter has published on this very nicely in looking at the importance of assessing the microvasculature after PCI in patients and trying to understand why some of our patients, despite the fact that they have a patent vessel, do not recover. And the predictive ability of contrast perfusion echo to differentiate these patients, if there's normal perfusion versus abnormal perfusion, is just amazing. And so this can be extremely helpful in that patient population. This is another, just to elaborate on the COVID application. This is actually a case that came from my colleague in Toronto, Dr. Jillian Nesbitt. She sent me this because it was very interesting. And this was a young woman who had come in with being COVID positive in cardiogenic shock and was put immediately on ECMO. And you can see here that despite her profound left ventricular systolic dysfunction, she has robust perfusion throughout her myocardium. And she was treated supportively, and amazingly, she had recovery of her function, as you can see here 4 days afterwards. So this enabled the decision to remove the ECMO catheter, or ECMO system. And then this is again done prior to her dismissal. She had excellent complete recovery of her LV function, and she has normal perfusion. So she did go on to have MRI, and her findings were consistent with a mild myocarditis. Sorry, that went backwards on me. There we go. I don't know what happened there. Apologies about that. Okay, so one last thought about how we can use contrast imaging too. That's getting a little more out there, maybe a little more research, but this is near and dear, particularly to Steve's heart, I know that. And this is a B-mode image of a carotid artery. And we have noticed that if we look at the plaques, you can see the plaque with calcification here in the B-mode. And if we look in this image, we can clearly see that there are microbubbles which will enter into this plaque, almost like a tube of toothpaste. It looks like little bubbles coming in here. This is obviously the lumen, which is filled with the flow in the carotid luminal artery. But you don't want to see these microbubbles in there, because that, we have learned, is a marker for poor outcomes in patients, as like a biomarker assessment of the vulnerable plaque. So in summary, I've kind of quickly gone through with case presentations what the indications are for our ultrasound enhancing agents, and this comes from our guideline documents, with cases of really, where you need to think about ultrasound enhancing agents can be helpful in your lab, in your everyday practice, and as well as evolving to some newer applications that you should watch for coming down the pike. Endovascular leaks, that's another very exciting avenue. I'm sorry, this is not playing for me right now, but instead of having to do serial CT assessments on these patients that have had aortic endovascular repairs, looking for microbubbles extravasating can be very, very helpful. So when do I use contrast? Well, when I can't get the information I need, if it's an indication that I know will be helped by contrast. And we've reviewed these. It's not only helpful to make a diagnosis, but also for prognosis, safe and cost effective, as Jordy has told you. And please use very low mechanical index imaging as your default imaging, because then we get the best endocardial definition, and as well, you can get the incremental information of perfusion. Watch for those newer applications to be able to enhance our detection of early atherosclerosis and vulnerable plaques, as well as assessing without the need for radiation other vascular applications. So thank you for your attention, and I think we're going to move into the Q&A session, so happy to answer any questions. Thank you.
Thank you very much, Sharon. That was a tour of strength of contrast. You cover every single aspect of contrast in daily clinical practice. Well, it seems that contrast ultrasound was made for stress echo, really, and I cannot imagine now how people can do stress echoes without the use of contrast. It appears that in one test, you can have anatomy, you can have function, and you can have perfusion on just one sitting in perhaps 20, 25 minutes. It's all over, all done.
All at the bedside. You don't have to get into a big machine that costs millions of dollars.
Absolutely. And Sharon, do you do the perfusion on the same sitting, or there was a question whether you do the perfusion on the same sitting or you have to call the patient on another day.
Oh,
I think
no.
Kelly asked that question. I saw the comment come up, and you touched on it, Sharon. Very low MI imaging is not just turning the MI down, and this is a concept that is that Tom Porter has been speaking about for 20 years. Go ahead, Sharon. The question is, do you do it at one setting, and do you just turn the MI down?
No, because we're actually already imaging at low mechanical index. And it is, as Steve is implying, it's not just that you turn the MI down. I mean, you use the preset that is the very low mechanical index imaging, because this is going to use our multi-pulse imaging sequences, which have been tuned to be able to enhance microbubble detection. So whether it's using the strategy of amplitude modulation or power modulation, or whether it's using pulse inversion, or different vendors use different strategies, but you want to use the contrast specific imaging strategy, and the one that is at very low mechanical index is the preferential one these days for being able to optimize your imaging of your microbubbles. And then, because it is so sensitive, you can also image the myocardium, the perfusion within the myocardium. So all it takes is to add that one extra step of making your box of your mechanical index flash, your high mechanical index flash, over your myocardium and your left ventricular cavity fill, to then deplete the microbubbles, so that then you see them replenish. So yeah, you do it all at the same setting. There's no need to call the patient back. You can get all the answers in the one setting. And Jordi and Steve and Petros, please elaborate with what your thoughts are.
Well, absolutely. And in fact, at Hammersmith, we do 100% of stress echoes using contrast. As we put an IV cannula for the dobutamine, as we do most of the stress echoes, then we do the same for the contrast. So no problems at all. Our sonographers are trained to cannulate and to give the contrast. No problems in the UK. I hope in the US you will expand on that as well.
The interesting thing, and I actually think you have an advantage in the UK in having had the opportunity of, side by side doing demos with you on, live in your Hammersmith program, is very impressive. I would put a plug for the Hammersmith Echo program. It's extremely a very valuable program. The advantage, I think, one of the things, the contrast agent that's primarily available, others are now, but the first agent on the scene in the UK and in Europe was one that came with a pump. And so having that pump automatically, so you're doing an infusion, what that causes is a steady state of the microbubbles within the myocardium, so that, here we don't have to use the pump. The agent that we have that's similar or the same that was licensed here in North America doesn't actually have the pump come with it. So it's a different kind of strategy. But you can, so we've been using, based on Tom Porter's work, more primarily the low or the slow hand infusion to replicate a pump slow infusion in that regard. But I do like the pump because it does take off the one more thing that you have to deal with, like during the actual technical performance of the procedure. So I do think that's helpful, and it's imperative if you're going to do quantification, because you do need to have the steady state. But mostly you don't have to use quantification. We can just use eyeball assessment of the replenishment of the microbubbles, which is adequate.
Sure.
Yeah, to build on that, I mean, I think you're absolutely right. You said a number of really critical things, Sharon, which is that if you're giving you're doing an LVO examination, it's imperative that you have those multi-pulse techniques working, as well as if you're using it for myocardial perfusion. If you just image and turn down the MI, that does not make a sequence that is a contrast enhanced sequence. There's a lot that goes on under the hood in terms of making sure you get optimal resolution of both the borders, but also of the myocardium itself as you're filling. So it's really, really critically important that just turning down the MI knob is not the same as doing a sort of programmable multiple setting. And I think that's important. And There are, I really like the pump. I wish we had a commercially available pump in the United States. Stay tuned. But I think that people have gotten around this by both doing the hand agitated and hand setting, but also to just sort of agitate an infusion of a pump. The most important, if you have an infusion that's ongoing, you can do an infusion. But the most important thing is that to let the microbubbles settle, because they will settle over time. And so making sure that you're sort of periodically agitating it by hand can be very helpful. The nice part about the infusion is you can set your levels, which is you can really make sure you're getting to a steady state where you really see things very well. And it's a little bit harder to control time varying findings. It's a little harder to control with a bolus. Now, one thing I do see that people do sort of poorly a lot of the time is people give a very small amount of contrast and or ultrasound enhancing agents, and then they see swirling at the apex. And that swirling at the apex is not necessarily demonstrative of it's not like spontaneous echo contrast. It's not demonstrative of a clot per se. It can be that too little contrast is given, or that in fact the MI may be too high, for instance, in those circumstances. And so there are a couple of things that you can troubleshoot with that. The converse is also true, which is you don't want to give too much because you get this blooming artifact and it can overwhelm things. And so finding that right steady state is really, really important. I actually had a question for Dr. Mulvey. So in your experience, you mentioned early on in a case of masses and distinguishing out the myxoma from the metastatic tumor in terms of the timing of the uptake of the contrast. What do you use as your sort of rule of thumb in those circumstances to say that something is highly vascular, that it'd be concerning enough for it to be a malignancy? And is there a framework in which you think about that, just for those listening?
Yeah, that's a really good question, Jordy, and it relates to the rate of appearance as well as the constant or the volume of appearance, right? And so if it appears rapidly, then that is more concerning. And clearly, if there are more microbubbles in the mass, then that is more concerning for the very high flow state, a very vascularized structure that is mass, as opposed to a slow rate of appearance with a lower concentration of microbubbles seen in the. Now, what are those numbers? It's a semi-quantitative assessment, right? And certainly you could quantify it, and it can be quantified by doing video densimetric analysis. But I think that really the clinical information is that, differentiating from no perfusion when you're more confident that that is then is a thrombus, most likely, right? So if it is perfusing at all, then that patient has bought themselves, obviously, further investigations and evaluations, right? So you're going to be clinically very suspicious, and then the other ancillary factors about the appearance, like that one has stalk, so it's more likely a myxoma, it's slowly perfused, makes sense, but they're still going to go for a cardiac MRI, or TEE, depending on what the clinical impression is. So you can't make a tissue diagnosis, obviously, using ultrasound enhancing agents, but it certainly can expedite your further evaluation and stratify what the most cost-effective way is to achieve the final diagnosis. Steve, you have a comment there?
Yeah, thank you, Sharon. And again, great presentations by everyone. And of course, Petros is the master of ceremonies. Let's just go back to the question, why aren't we using more contrast? Jordy, I liked all your answers. I think there's additional answers. There's economic issues, there's time issues. I think the literature is replete with the information why you should use it. It still baffles me that it isn't picked up to be used more, because it not only is qualitatively better, but it saves lives. All right, just who do we use it on? We often look at the charts and we see if the patient's a return visit, they've had contrast use, we use it again. But Jordy, you've come up with a little bit of a method that the listeners may or may not be aware of. It's a predictive score. And could you expand on that?
Sure. Yeah. Thanks, Stephen, and thanks for bringing this issue up because I think it's an important one. So, Mike Main has talked about how there may be benefits of using contrast in all inpatients. So, from an inpatient standpoint, they have an IV already. Just use it. You learn a lot of information, and I think, as Sharon mentioned earlier, you learn information even on patients who don't necessarily have a poor image quality. You really have a lot of information that you can glean off of both with perfusion information as well as find certain things.
Just one point on that. I'm in agreement with Mike and you that, yes, we use it extensively for inpatients. Let me just bring up the economics of this because most of the inpatient medications, are not covered necessarily for reimbursement. They're under a DRG in the USA. So you're paid for diagnostics, not additional applications. Now, I will say, and I'm sure the group listening is well aware of the P&T committees that determine what drugs can be used in your institution. Now, the more times you do the contrast as an inpatient, the more the institution will have to cover the cost of this. Now, I agree with you and Mike. It's a cost benefit. It saves lives. It just improves discharge early propositions. That is an issue.
Yeah.
Because an inpatient is a cost borne by the hospital, not by the insurance companies. So while it sounds good, we have a problem oftentimes pushing that through the P&T committee. Would you like to, and Sharon, expand on that a little bit?
Yeah, I think definitely. I mean, you get a set cost for a DRG payment in the United States, at least. And so, what you do within that hospitalization is essentially counted against the overall revenue for that given hospitalization. So, if the procedure costs more, then ultimately that's less cost, that's less revenue for the hospital. So I think that is always a challenge. Nevertheless, you can make the justification by saying that in those sick acute patients, you're using less downstream procedures, and so in net there may be a significant cost savings, even though the upfront cost is a bit more. Now, getting to your sort of earlier point about the algorithm for identification of use. So this has been sort of very interesting. We think that it's not just whether or not they use contrast beforehand, but we think that the three most important variables that we found in our research that really predict the presence and need for contrast. And so not just the presence, not just if somebody got contrast, but if they had contrast or they had suboptimal image quality and potentially could have used contrast and it wasn't given, were age, weight, and that not BMI, not BSA, but weight actually seemed to be best predictive. And then heart rate, which we think is more sort of an acuity, marker of acuity for the given patient. And those three variables combined, we can create a risk score, which actually has sort of a lot of predictive ability. We've validated it subsequently at Mid-America Heart Institute, and we have now turned it into a calculator, which is available on the ICUS website. So I would go, everybody, if you go to ICUS Society, and you can go under Getting Started, and under there is a box for CEUS calculator. And you can see, you can enter in somebody's weight, age, and heart rate, and it will give you a probability for contrast use. And there's a box saying that if the contrast, probability of contrast need is greater than 15%, then you would consider an IV to support. Now, what we're not trying to do is replace people's clinical opinions and review of the images. That's really critical. But what we're suggesting is that you could have an MA or somebody else go through the night beforehand, the week beforehand, as you need to, and identify who needs to come in 15 minutes ahead of time to get their IV placed and to be consented for contrast. So there's a workflow solution there that might hopefully help some labs in adopting this as an outpatient.
So, Jordy, I just brought up the app here. Have we got the calculator on the app yet? Because that's actually one of the next questions I just saw too. How can we use the ICUS app? So we got that on there?
Steve, I don't believe so yet, but it links to the website. And if you go to the website, you can certainly find it on there.
That's right. At the very bottom, it gives ICUS website. And if you link to the website, it is on the website. Okay. All right. But the next step, we have to get them to put it on the app too, so that people don't just use it on the phones, right away with one step. It's very helpful. Yeah, and I'm sorry to jump ahead, but I did notice that was a question there, and so that just tied right in with how can the ICUS app help to help our use. Obviously, you know, I'm so glad that there's awareness of the ICUS app out there, number one. It is very, very helpful. And if none of you have it, then it would be great to download it. There's all kinds of little tabs here. And you'll also get the Bubble blog, Bubble TV. It really gives you pretty much everything that is on the website, or can connect directly to the website at your fingertips. So, you know, for payment and coding in particular, there was a comment earlier about CPT codes. You know, Jordy was talking about that. You know, with respect to the issue of downstream effect, you know, being in Canada now, medicine is a service and it's not a business. So it's a little bit of a different it is obviously somewhat of a business too, but it is a different perspective in that regard. And so I think that we're all about what can be most efficient in the utilization of our resources for our patient care. And many hospitals don't have the big box resources that are very prevalent in the practices in the US. So the opportunity to be able to utilize contrast ultrasound enhancement in areas that have less robust resources perhaps than in other countries is huge. And it just takes, again, it's interactive education and training. Intraoperative, like we have, it really is totally dependent on operative skill, operator skill, ultrasound, we know, and then certainly it's another step in the technology to be able to understand your technology and your skill required. So I would encourage everybody to go to the ICUS website. We have really excellent resources there, and part of that are these webinars that we're putting on, and we are so glad to see you here, and hope that you will come for more.
I just wanted to quickly say that I was mistaken. I was corrected here. It is on the app. If you go to the clinical research, there's so much material that it's in there though.
Which tab is it under?
Resources, there's the CEUS calculator, and it's right at the bottom there. So you can
CEUS calculator, Sharon.
Okay. Yeah. All right. Awesome. Okay. Oh, at the very, very bottom.
Well, we should move it up.
Yeah, just a couple from the top. Excellent. It is there now. I didn't go down far enough either. Okay, so just scroll down. I got it. CEUS calculator.
Thank you.
Perfect. All right.
Okay, I think time is up. I don't see any other questions, Steve. Do you want to wrap up the session and conclude?
I'm going to allow you that opportunity. It's been great seeing everybody and sharing with you, Petros. Please go ahead. Tell us your views from Athens.
Well, we heard everything. There were fantastic presentations trying to convince, if there was any need, to say the least, that CEUS in daily clinical practice is a must. The visualization of the left ventricular apex is a must. We think about 70% of the examinations that we see the apex, but in fact we do not see the apex. So if we want to see the apex of the heart properly, we must use contrast. Jordy showed some very good examples how some off-axis views, you think you see the apex, but in fact you don't. So imaging the cardiac apex and all the pathology that comes with it is a must for the use of CEUS, and this is for daily clinical practice. How many echoes we do every day, we think we see the apex, and in matter of fact, we actually don't. So use contrast for visualizing properly the apex. Also visualizing the right ventricle. We saw some very good examples of hypereosinophilic syndrome that affects the right ventricle as well. So focus on RV views to image properly the RV and, in fact, the RV apex. Well, I would say a stress echo is a must. Stress echo without contrast, I would say, is not a stress echo. You think you do a stress echo, but in fact, you don't. So use contrast for stress echo. Sharon and everyone showed some fantastic examples how with one examination we can have anatomy, look at the valves at the same time, briefly, but look at the function of the heart and perfusion. I remember, Steve, some years ago in the States, you were afraid to pronounce the word perfusion because it was not FDA approved,
Right.
blah, 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 blah. Well,
Right.
this we in Europe, Roxy, myself, and others in Europe were pushing, use perfusion. And in fact, the European guidance was to use perfusion as opposed to the American Society of Echo guidelines. So now I'm pleased to hear that you adopted widely the word perfusion. Use contrast for myocardial perfusion. It is a must. It is inexpensive, it's easy, and in one examination, you have anatomy and perfusion in one go. So, Steve, I think it was a marvelous webinar. I think we covered a lot about it, let alone cost effectiveness. That Jordan has made a very nice, sophisticated analysis. But I think overall I enjoyed the session. I think we all enjoyed it. And I hope that this will raise the rate of the use of CEUS in the United States and beyond.
Thank you.